this audience, I wasn't actually going to give a very sort of much of an introduction into the sociological diagnosis, because I assume that you all know it really. I'm going to take Mildred Blackstone as my starting point, and her observation that actually when you talk about diagnosis, it evokes a whole range of social and cultural themes, not just about the diagnostic process itself. And that diagnosis itself is such an important framing tool in relation to medicine. But not just clinically, it's social framing. It, I suppose, reflects a whole range of normative values and assumptions, and of course defines what is normal and what is not normal. And what I want to do is take those basic ideas and apply them to a very concrete area, antenatal screening for sickle cell and thalassemia disorders. And in doing so, begin to problematise the idea of screening, problematise the idea of risk, and actually start to question what actually is being diagnosed, for what consequences, and for what purposes. Because antenatal screening does raise these questions in a particularly complex way. And what is more, policy in this area is quite confused about how it answers them too, and actually follows many different ideas simultaneously, but ultimately contradictory. I don't want to say much about sickle cell thalassemia. You don't need to know much about them to understand the presentation, but what I will say, they are the most common genetic conditions in the United Kingdom. There are around 500,000 people who are genetic carriers of the condition, and they are both recessive disorders, which means that if two carriers were to get together, there is a 1 in 4 risk in every pregnancy that their child would have either sickle cell or thalassemia disorder. And what makes them especially interesting as conditions, that since 2001, England and Wales have had a coordinated antenatal screening policy, i.e. the intention to screen most women as carriers of sickle cell trait during pregnancy, during antenatal care, which is connected to a neonatal screening programme. And the point of that is to universally screen all newborn children for sickle cell disorders. So you've got these two programmes. The programmes, quite rightly, are based on these principles of choice and individual preference. And I am fully committed to that. However, in some ways, policy, and I should also say that policy is also committed to that idea of choice, but at times it can appear incredibly naive and uncontextualised. And if nothing else, and it's something you may want to talk about later, there's a real danger that future generations will judge us as harshly as we have judged previous generations around how we screen antenatal conditions. And I said that is something we can pick up in the discussion. Now, again, context. I'm not going to go through this in detail, but I put this up because actually it just illustrates the complexity of what happens when a woman is pregnant. And a whole range of tests, some aimed at the mother, some aimed at diagnosing conditions in the unborn child, some are also aimed at the father. So there's a whole range of different purposes, reasons, and perhaps understandably, they can become confused in practice about what actually is going on. And within that, as going back to what I said right at the beginning, we've got medicine, which is rolling out technically the ability to facilitate a whole range of timely interventions that appear to increase the choices available for the individual, which gets at this idea of normative values and assumptions. And it's a dynamic tension between those two, and in a sense, sort of gives us the boundaries of practice around antenatal screening. And yet, despite the fact, internationally, and certainly in the context of England and Wales, screening for sickle cell and thalassemia has been around for an awful long time. But even saying that, there's a whole range of practical difficulties and ethical dilemmas we're yet to resolve. And I'm going to give you one that sounds like I'm exaggerating, but it isn't. It actually did really happen. When they set up the neonatal screening programme for sickle cell in England and Wales, which, as I said, is the identification only of children with the condition, the NHS and policymakers didn't quite understand that the current test we have for identifying those with the condition would also pick up all the carriers too. And believe it or not, they wasn't prepared about what to do with this information. They'd got all this information, which they didn't think they'd get, so what did they do with it? A lot of NHS trusts actually destroyed the information. just got rid of it. We might want to debate the ethics of that, given that that information could be incredibly valuable. In other cases, they did the next best thing. They wrote to general practitioners. That's not criticism of general practitioners. But what would a general practitioner know what to do with information? All they got is a letter. This child is sickle cell trait, this thalassemia trait. No other information. Perhaps worse too, they actually wrote to the mothers. All the mothers would get, given that they have consented for a test that would identify a condition, a disorder, they get a letter saying, your child has sickle cell trait, your child has thalassemia trait. For further information, please contact your GP. Can you imagine how anxiety-provoking that would be for mothers too? And actually, the situation is beginning to get, I think, even more bizarre. Wales is well aware of these problems. He's actually thinking of introducing a less accurate test for sickle cell disorders, but one that has the advantage of not picking up all the carriers. Now, you might want to debate clinical consequences of that, but these show some of the problems, some of the difficulties that we have of trying to identify people at risk of either sickle cell or thalassemia. And underpinning all that, that was just one example. Informed choice, how realistic is it to be able to achieve informed choice? I think the tension was brought home to me by a conversation I had with a senior NHS manager responsible for screening when I was talking to her about what are the purposes of screening. And she simply said without thinking, oh, it's to prevent by giving an informed choice. And that's the fundamental tension that we have here, is that we have a screening programme that is all about choice, but underpinning that is this idea, this conception that really it leads to prevention of the condition, which is ethically something quite different. I'll give you various examples of how that is expressed in policy and practice, although it would be true to say, and for reasons that I go on to, policy and practice doesn't like to openly discuss these issues. It's really difficult to raise them at meetings. The other thing that I should have said right at the beginning, one of my roles here is that I have a position as chair of public outreach for the National Screening Committee. I'm fully well aware at these committee meetings and committee meetings more broadly how difficult it is to accept informed choice may be undermined. And it's undermined in various ways. Take a simple, straightforward outcome measure in England and Wales, of which payments are made for NHS Trust if they achieve. The outcome measure for screening is how many women take up the test. If you're serious about choice, it should actually be how many women are offered the test. It's just an example of how subtly this process can be undermined. You get a similar thing going on in Down syndrome, screening for Down syndrome. The UK has some of the lowest rates of uptake of CVS for Downs in Europe. And policy sees that as a failure. It might not be a failure, actually might be an example of good practice, because we know that the women receiving, the women offered these tests are the same across Europe. It's just the uptake that's different. But policy has constructed that as a failure, but in fact it isn't. It might be a really good expression of choice. You can't escape any screening programme or any discussion about screening without engaging with health economics either. And health economics is actually quite unhelpful in this matter, because the whole idea of screening either genetic conditions or conditions more broadly is that the only way you can make them cost effective is if you actually prevent the condition. If you reduce the number of people with the condition, your programme is then cost effective. And although, again, it's not explicitly stated, this underpins some of the policy assumptions around screening, antenatal screening for sickle cell and thalassemia. As a consequence of that, you're dealing with potential eugenic connotations. Weak eugenics, and you might say, is there a problem with that? That isn't really the issue. The issue is that we're actually not debating it, and I've come to talk about the real consequences of that. The very fact, and all mothers will point this out to you when offered tests, whenever you screen in pregnancy, particularly for sickle cell and thalassemia, it can't help but imply that the condition's a bad thing. The very fact you've offered the test is no longer neutral. Mothers will tell you that. You're telling me that I have a choice, but why would you offer me the screening in the first place? There must be something wrong here. And I think you have a problem, is that the very fact you have a screening policy might be beginning to presuppose the undesirability of the condition. And it's very difficult to escape the idea that the whole policy is to reduce numbers of people with that condition. And why that is quite important in the context of the UK is for reasons I will go on to. If you compare sickle cell and thalassemia disorders, which largely affect ethnic minority populations in the UK, not exclusively, but largely, and compare it with cystic fibrosis, which largely, not exclusively, but largely affects Northern Europeans. For every £1 spent on screening for cystic fibrosis, £8 is spent on screening for sickle cell disorders. And given that this is targeted ethnic minority populations, you can imagine the kind of assumptions that may entail. Especially if I were to tell you that for every £1 spent on the care of somebody with a sickle cell disorder, £8 is spent on the care of somebody with cystic fibrosis. Almost title opposite. And that's not to say that people with cystic fibrosis don't deserve that care. They do. It's an awful condition. But the very fact, it sets up a series of assumptions within that debate about where your focus is. For sickle cell thalassemia, it seems to be focused on screening. And certainly one of the things that concerns us, those who have worked in the area for many years, that has been totally disconnected from the debates around care. So your resources are going to screen for the condition and not to care of the condition. And that, I think, will create problems for us in the future. And this, I noticed in the audience my good colleague and friend, Peter Chatton, who actually came up with this data. And I do say he came up with it because, again, it's part of the difficulties, the complexities and subtleties of policy documents, in that you actually have to work to find this data. But it actually really clearly shows the position about how difficult it is not to have a screening programme that increases the number of terminations. We know, you just look at the figures here, we're seeing an increase from 2008 to now of the mothers who accepted prenatal diagnosis. And you look at the rather large rise in terminations. So you've got 28% in 2008 and 9 to 45% in 11 and 12. A much larger increase of thalassemia as well. And all this is the consequences of just having a screening programme with nothing else. And again, it's undermining some of those ideas of how much choice people really operate. And if you take that further, and looking at what is going on here, there's a whole range of just straightforward practical difficulties that occur in practice, which are often forgotten in debates. Now, if you're serious about antenatal screening in many conditions, we should be identifying really early in pregnancy, largely because we know, the evidence tells us, that women are generally reluctant to consider prenatal diagnosis and termination, but if they were going to consider it, they want it during the first trimester. Anything that is outside the first trimester is exceptionally problematic from a woman's point of view. They are reluctant to even consider prenatal diagnosis and termination during the second trimester. And therefore, you need an NHS system that can screen women early, whether it's for sickle cell or whether it's for Downs. Little wonder it doesn't happen. The target is 90% of women within 10 weeks of gestation for sickle cell and thalassemia. The best available evidence we have suggests it's achieved in 22% of cases. So we are well short of that figure. And what perhaps makes these figures even more stark, remember this is a recessive disorder, actually of that 22, only 10% of the fathers are tested. Pretty low figures. And actually we have good evidence that some of the mothers are actually going forward with prenatal diagnosis, which always carries a risk, without the test results of the fathers, which again is incredibly problematic. And it gets more problematic in a way because this connects up with certain racial stereotypes, racist assumptions, because there's an idea in policy and practice that the African Caribbean, and now the African father, is feckless, not interested in pregnancy, not interested in the mother, not interested in families. Obviously, we know the literature on that, absolute nonsense. In fact, we have some really good work from colleagues in Nottingham, Joe Kye, Louise Lubbock, who's actually telling us that fathers are quite interested in screening actually, and will consent to test if offered. The fact is, they're not offered, sometimes because of these assumptions about their commitment to the pregnancy. Equally, the women themselves, particularly ethnic minority women, get blamed because you talk to policy, practitioners, and they will tell you one of the reasons they don't meet the target is because women are not presenting their pregnancy early enough. And that is seen as a particular problem for ethnic minority women, but particularly women of South Asian origin. The figures are there, this is really good data. 75% of women report their pregnancy within 10 weeks gestation, an amazingly high figure. And there's actually no ethnic differences in that whatsoever. But again, it's a racist assumption that's used against the women to blame them for not reporting their pregnancy. Then there's something I've already dwelt on. The knowledge and training of professionals is a problem. Their ability to engage with cultural diversity. But also, to be fair to them, if you talk to your average GP, they will say to you, they've actually been trained to offer choice. It's not part of their medical training. And therefore, why should they be expected to be up on the complexity of current debate? And interestingly, it's something the women pick up on too, because what they say, they point out how difficult it is to make a decision about a condition when you've never heard of it, which happens quite regularly. And if you've never heard of it, of course you're going to trust a healthcare professional. Mothers will say that. Well, they're the healthcare professionals, they will know far more than me about this condition. And actually, practitioners do get very asked very direct questions. What would you do in my circumstances? So the women themselves have very interesting expectations of choice. And also we know, again from the broader literature, is that they actually may not be aware of the tests they've done. I showed you that slide earlier on. It gives you the broad range of tests they have. Consent at best is implicit, and often just presented as routine care. So the mothers themselves are not sometimes aware of the consequences of all these tests. They agree as a package, it's routine care. That's what happens when you're pregnant. So there's no real sense of what they're consenting for. And that's why, when a problem is identified, there's all sorts of difficulties and problems. The mothers are largely, and the fathers for that matter, are unprepared for it. Also, the mothers are agreeing to these tests anyway as a package of care, because they think they're just going to confirm the pregnancy is healthy. In most cases that will be the case. But actually, in some cases, it won't be. And again, they're unprepared for that information. They're also connecting to these normative values and assumptions about what a good mother would do. And if you talk to mothers, they do actually locate their narratives within these sorts of debates. And to them, a good mother accepts routine care and accepts these packages of care, because the good mother has a child who is healthy. And that's, again, undermining some of their ideas of how they can exercise choice as well. And something that perhaps should concern us is that when mothers make decisions around antenatal testing, prenatal diagnosis, termination, of course they take into account severity. Sometimes in many conditions that's very difficult. Sickle cell, thallasemia, Downs, very difficult to actually say why those conditions are going to be. But interestingly, it's not just clinical. They make judgments about how society treats people with disabilities. And of course, as long as those are negative connotations around disabilities, that will lead them ultimately to ideas of prenatal diagnosis and termination. And all this is just an example of undermining those ideas of choice. I mean, yes, they have individual choice, but they can't help making them in relation to those broader societal norms and values which ultimately can undermine that sense of choice. And just another example, I'm drawing towards the end, just two examples I just want to sort of further problematise it. I'm not going to say much about religion, but it again connects up to the complexity of debates, because if you look at policy, and not just UK policy for that matter, you can look at global policy, public health policy around screening. There's this idea that religion is a problem. You've got to overcome religion to have a successful screening programme. That's certainly written in UK policy documents, but I've seen it across the globe too. It's certainly a feature of WHO views on screening for sickle cell and thalassemia too. But of course, I don't need to tell this audience that a person who holds particular religious beliefs is hardly, and in most cases, a primary aspect of their identity. They use it in conjunction, in connection with other aspects of their identity. It's an incredibly complex resource, and an individual resource too. And it doesn't, perhaps not surprisingly, provide a rigid sense of right and wrong. Whereas interestingly, all major religions, Islam, Hinduism, Christianity, Judaism, and so on, Buddhism, Sikhism, actually pretty much doing the same thing. It's not much difference in what they are trying to do here, but they are using their religion in an incredibly creative and individual way. Of course they use it in other contexts. That might be ideas of severity, it might be how many children they have in the family, it might be the impact of that pregnancy on their partner, their family, and so on. Part of a much broader context. It doesn't predetermine behaviour. May predispose, but it certainly doesn't determine. And also, theologically, most of the major religions make a point, that's obvious, because God's given you free will. And if you don't have free will, not much point in having a God. There's actually a theological basis to this decision making, which challenges some of the unsophisticated policy debates. And as I said, ultimately, it's about personal judgments, personal values. That's why you may have two leaders who will use their faith, their religion, to justify their decision to terminate or not to terminate. Certainly occurs in Islam too. Certainly there's a whole body of work on this, including work that I've done in the past, talking about how people use their faith to make sense of termination. And I remember doing a first group discussion with a group of young Muslim men, and the subject of fatwas came up. Fatwas are based in religious rulings. And in this area, there are various fatwas allowing Muslims to consider termination within 120 days of the pregnancy. And some young people in that group were saying how useful it was to know that and how they would use that to inform their decision. Other Muslims were saying that was utter nonsense because these fatwas were enacted in countries such as Pakistan, Saudi Arabia, Lebanon, where the healthcare system, the expectations were very different. Therefore, they had absolutely no value to the United Kingdom. And so, people with overtly the same beliefs and values would come to very different decisions. And that's a common feature of this. People who use their faith differently and creatively. And even if they share the same faith beliefs, they won't actually come to the same decision. And what's more, that decision also changed over time. You'll get some parents who will decide their faith wouldn't allow termination in the first pregnancy, but comes to a very different conclusion in the second pregnancy. It's a little wonder because, again, irrespective of religion, the same dynamic is going on. Most religions accept that taking a life is a sin, but at the same time, most religions have a, as you call it, a moral categorical imperative to prevent suffering. And how do you balance those two when you're considering the pregnancy, but actually decide whether you decide to terminate or not, or acceptability of termination to you? It's a dynamic process. Interestingly, what is fascinating from the literature is that atheists and agnostics seem to be using the same dynamic as well. This idea that you shouldn't take life, but you prevent suffering. But again, all this is missing from that complexity of how we try to identify at-risk couples. And you can broaden this debate because what antenatal screening has done, because of its imposition about what it is doing, is it sort of shifts the biomedical norm. If you look in WHO classifications, sickle cell and thalassemia trait are actually regarded as disorders. But it gets more complicated than that because although the carriers of the condition are generally benign, and they are essentially benign, they may have one or two clinical consequences. It's really confusing if you try to get that message over. But as I said, they're largely benign, but with one or two clinical consequences. But again, that doesn't stop these connecting with broader assumptions. Certainly in the United States, being a carrier of sickle cell trait has actually been used to deny African Americans access to sports scholarships, very prestigious in the United States, but on the simple basis that they have sickle cell trait and therefore at risk of sudden death. Evidence is not there. There's quite a lot of quantitative, real detailed epidemiological studies on this. It just isn't there, which it connects up with that racist assumption to deny African American access to these sports fellowships. So that debate is always there. And I'm happy to discuss that a little more in the discussion because it is incredibly complex debate. And of course, it raises, in all this screening, who actually owns this genetic knowledge? We're talking about recessive disorders. Do you have a moral, a social obligation to disclose your test results to your family members, given the chances are they also carry the condition? And that is very challenging. It's challenging for parents, families, and it's challenging for healthcare professionals too. Healthcare professionals especially struggle with this It is quite interesting that the UK Royal College of Physicians, about 2 or 3 years ago, they quietly changed its guidance on confidentiality. So quietly that I suspect many of you never noticed it. But what they changed in their guidelines to their members was that for certain genetic conditions, it is possible to disclose to certain family members the results of those conditions. Now, it didn't say what those conditions were, and it didn't say who those family members were, but it does start to undermine some of the ideas of doctor-patient confidentiality. You could argue it's sensible, but again, there was very little debate around that. And all this about the simple matter of trying to understand a pragmatic policy response to rolling out antenatal screening. That's all I wanted to say, really. What I'm trying to do in the presentation is try to understand how it's very difficult in antenatal screening to connect with broader debates around the sociology of diagnosis, and how difficult it is to really facilitate individual choice, although I would argue we definitely need a commitment to that individual choice in practice. And this sense about how, when you get into practice, just how messy it becomes. And underpinning that goes back to something I said right at the beginning. The problem around antenatal screening is we're still not absolutely clear what is a diagnosis. There's confusion about whether it's diagnosing carrier status or the actual condition, for what purposes, and of course, with what consequences too. And all this tends to actually make it quite complex. And given that antenatal screening isn't going to go away, it's going to be rolled out for even further. We've got preconceptual screening, identifying children as young as 14 at risk of sickle cell, thallasemia, Huntington's, whatever. And it's just that there hasn't been a clear-cut debate about what they're actually trying to achieve and what are they diagnosing. I'll leave it there. Thank you very much for listening. Thank you.